Thank you all for joining the NIA's webinar today, the overlooked issue of shingles infections in older Canadians and how we could address it. I'm Michael Nyson, the Executive Director of the National Institute on Aging and your moderator for today's virtual event. The National Institute on Aging is a Toronto Metropolitan University, formerly Ryerson, think tank focused on the realities of Canada's aging population. Through our work, our mission is to enhance successful aging across the life course and to make Canada the best place to grow up and to grow old. We are Canada's only think tank dedicated to policy solutions for an aging population, and we work at the intersections of healthcare, financial security, and social well-being. Today, of course, we'll be focusing on shingles and on the importance of vaccination, especially for older adults. Despite potentially serious health outcomes, shingles remains an overlooked issue in Canada, particularly for older adults. Canada's National Advisory Committee on Immunization, also known as NACI, recommends that all adults aged 50 years and older be offered the recombinant zoster vaccine to provide protection against shingles unless there are contraindications. Despite this recommendation, only 27% of Canadians in this age cohort reported having received a shingles vaccine, with rates varying considerably across Canada's provinces and territories, due largely in part to how the vaccine is either funded or not funded, depending on where you live. Today, we'll learn from leading experts, Dr. Samir Sinha, Dr. Vivien Brown, and Dr. Allison McGeer on the health implications of shingles for older adults, effective prevention measures, and evidence-informed policy recommendations and practice approaches. Dr. Sinha will kick us off with a high-level overview of shingles, but the majority of the event will be a Q&A so that you, our audience, can engage with our experts, ask questions, and have your most pressing issues answered by some of Canada's leading experts on these issues. So please do type in your questions in the chat function below. Feel free to do so as they come to you, and we'll prioritize them in the order that they're received and, of course, in the order that they haven't been answered. But before I introduce our panelists and we kick off the event, I want to take a moment to thank GSK for sponsoring this event. It's thanks to sponsors like GSK that the NIA is able to bring you educational events like this one. And now I'd like to introduce our speakers. Dr. Vivien Brown is a family physician and author in Toronto. Educated at McGill University, she currently is appointed to the Department of Family and Community Medicine at the University of Toronto, holding the rank of assistant professor. An award winner for teaching on many levels, her major interests are in the areas of health promotion and prevention for women, in continuing medical education, adult immunization, and vaccine preventable illness. Dr. Samir Sinha is the NIA's Director of Health Policy Research. He is a passionate and respected advocate for the needs of older adults. He currently serves as the Director of Geriatrics at Sinai Health System and the University Health Network in Toronto. A Rhodes Scholar, Dr. Sinha is a highly regarded clinician and international expert in the care of older adults. He is the architect of the Government of Ontario's senior strategy. He was also recently appointed to serve as a member of the Government of Canada's National Seniors Council and has been asked to lead the development of a new national long-term care standard for Canada. Finally, but certainly not least, is Dr. Allison McGeer, trained in internal medicine and infectious disease at the University of Toronto. She also completed a fellowship in hospital epidemiology at Yale New Haven Hospital in 1989. She is a clinician scientist at the Lunenfeld's Tannenbaum Research Institute at Sinai Health, and she has been a member of Canada's National Advisory Committee on Immunization and is currently a member of the Infection Control Subcommittee of the Ontario Provincial Infectious Diseases Advisory Committee. Thank you all for being a part of this very timely and important webinar. For anyone who's been reading the news, shingles is coming up more often than we're probably used to seeing it, and with good reason. And with that, I'll turn it over to Dr. Sinha to give us a little bit of a high overview of what we're talking about today before we go into Q&A. Samir?
Thank you very much, Michael, and thank you everyone for attending today. And it's great to have you here, and it'll be great to have a Q&A session with my colleagues. But just to get us started, we want to just share with you a few opening slides that relate to a recent policy paper that we published through the NIA that really kind of, with this exact same title, looking at the issue of shingles in Canada and what we really can do to address it. So we'll go to the next slide. So what is shingles? Well, it's a serious disease primarily affecting older adults. It can happen to people at any age, but principally, it's one that affects mostly older adults. And fortunately, it's largely preventable through vaccination. And before vaccines were developed, 1 in 3 Canadians were at risk of developing shingles over the course of their lives. Let's go to the next slide. And so what is shingles exactly? Well, shingles can lead to a painful rash with blistering. It's usually kind of a strip on a part of the body. And in addition, it can have other symptoms like a headache and fever as well. So it usually starts as a painful rash. It usually follows a nerve, hence why it can be like a strip, for example, or a specific patch along your body. And again, with that painful rash, usually the rash will go away after about a week or so, but sometimes you can have that pain syndrome that can last for a lot longer in particular. We'll go to the next slide. So age is the major risk factor for developing shingles. And people say, well, why is that? Why is it something that really affects older people? Well, it's mainly because the immune system tends to weaken naturally as people grow older. And that's why over 2/3 of shingles cases occur amongst adults older than 50 years of age. And so with each passing decade, a person's risk of experiencing shingles and what we call post-herpetic neuralgia increases as well. Go to the next slide. And so individuals also who have diabetes are at an increased risk. They're more likely to develop shingles. And if you are an older adult who has shingles, or you know us, or if you're an older person who has diabetes, or you know someone who has diabetes and they're not vaccinated against shingles, this is an opportunity to talk to your doctor about your immunization options as well, because there might be an enhanced reason to get vaccinated against shingles if you have diabetes. We'll go to the next slide. So shingles can cost our Canadian healthcare system an estimated $67 to $82 million annually, mainly because it can lead to more doctors' visits, sometimes hospitalizations, especially for people who are experiencing some of the more serious complications related to this infection. We'll go to the next slide. And Canada's National Advisory Committee on Immunization currently recognizes that, or recommends that all adults age 50 and older be vaccinated against shingles. But as was mentioned earlier by Michael, only 27% of Canadians age 50 and older report having received a shingles vaccine. And sometimes people say, well, this must be due to hesitancy, for example, that older people are not interested in getting vaccinated. Well, we've achieved much higher levels of vaccination for older Canadians around things like pneumococcal disease, influenza in particular, against COVID-19. Right now, 94% of older Canadians have received at least 2 doses of the COVID-19 vaccine. So we know that older adults are definitely interested in getting vaccinated, but there clearly is a gap, especially when it comes to shingles, as well as influenza and pneumonia, but especially shingles. And partly this is because of a funding issue, where in some provinces it is covered, and most of our provinces and territories in Canada, it isn't covered at all. We'll go to the next slide. And right now, in terms of when we look at some of the data, when people look at getting the shingles vaccine, it's been found to drastically lower the risk of developing shingles and maintains this effect for at least 4 years after vaccination. So right now you can see kind of this slide here that just shows one study helping to show how that effectiveness seems to last for at least 4 years and likely longer. And we always say that with this new vaccine that's been available since about 5 years now, it lowers your risk of developing shingles by about 90%. So really effective, and one worth being aware of. We'll go to the next slide. And so really, that's what I wanted to share with you, just a few things overall to think about. But now we can go into our Q&A. And so I'm going to pass it back to Michael so that we can have a conversation and also answer your questions as well.
Excellent. Thank you for that, Samir. We're starting to get some questions. And before I get there, just based on some of the comments you made and to lay some groundwork for people who might be newer to the issue of shingles, I know we take it for granted, especially coming off COVID, the sense that older people are more prone to it. But I'm wondering if we could just dig in a little deeper, and maybe Allison, if you want to start us off on why is it that older people are more likely to get shingles and should really be more aware of this? And some people at 50 might think, maybe I'm not an older person yet, but why should this be on their radar, and why does it matter so much for older people?
So the reason shingles matters for older people is not so much the shingles itself, which if you have a mild case is fine. It's that a proportion of cases are associated with what's called post-herpetic neuralgia, which is nerve pain that persists for weeks, months, occasionally years after you get the infection. So it's not that the disease itself is life-threatening. It's very few hospitalizations. You looked at the cost to the healthcare system is not overwhelming, but the cost to individuals who get post-herpetic neuralgia is just terrible. It's a truly dreadful thing to suffer from. And it happens predominantly to older adults, but it can also happen to younger adults, particularly immunocompromised younger adults who get shingles. Now, shingles is mostly a disease of older people. So if you think about it, pretty much all of us, before chickenpox vaccine was available, all of us got chickenpox as a child. You then live with that virus in your nerve roots and your immune system watches it, okay? Make sure that if it's thinking about doing anything, you do something about it. But it gets tiresome to be on surveillance all the time, you know? And your immune system weakens a little bit as you get older. And so periodically, the virus just escapes your immune system. It doesn't actually, when it happens, most of the time, it doesn't tell you there's something wrong with your immune system. It's just that your immune system was asleep at the switch, right? For not that long, maybe, but enough that it escapes. And so the older you are, the longer that surveillance has gone on for, the relatively weaker your immune system is, the bigger the risk that you're going to get it. And the vaccine against zoster is actually related to the chickenpox vaccine, just stronger. So it says, okay, immune system, we know you've been watching this virus for a long time. We understand you're getting tired of it. Let us give you a lesson in surveillance here, okay? Teach you to watch for it so that you boost your immune system back up and you get yourself another, well, you know, what we know is at least 5 years, but we're getting out to 10 years now. So hopefully the rest of your life protected from getting shingles again.
Excellent. And, you know, that's a really great bridge to a number of questions that are coming in along the same lines. And I'll leave it to you to jump in on the panel, whoever wants to. But generally, the questions are in the vein of, I got the vaccine X number of years ago. Should I get it again? So Betty in particular here said, I sent this in previously to us. I had Zostavax in 2013. Should I be re-immunized or is it good for life? And there are other variants on that question. So perhaps if you could touch on the various vaccines and what the duration is and what people should be considering if they've received vaccination some years ago.
Vivien, I think you've been seeing this question a lot in your practice. So
yeah. So Zostavax was launched in 2013. It's a live virus vaccine and it was a good vaccine. But the immunity did not last as long as we would have liked. The recombinant vaccine, or Shingrix, was launched in 2017, and the data is much more robust for decreasing your risk of getting shingles. You know, Samir showed that there's at least 4 years of evidence, but we actually know that it lasts a longer time and that immunity continues. So the question, if you've had shingles, the disease, do you still need the immunization? And the answer is yes. 1 year minimum after having the disease, take the new recombinant vaccine, which is Shingrix. If you've had Zostavax as an initial vaccine, do you still need Shingrix? The answer is yes, 1 year after having the Zostavax minimum. So most of us are not using Zostavax in practice anymore. So most of the shingles vaccines that we're using is Shingrix, and it's 2 shots, 2 to 6 months apart, ideally.
Excellent. Samir, Allison, did you have anything to add? Or?
No, Vivien nailed it.
Yeah. I would just add that I think it's really important in Ontario, and I'm not sure if we've got people online from all over the place, but in Ontario, the public health pays for it if you're between 65 and 70. So if you're in that age group and you haven't yet been vaccinated, you absolutely should take advantage of the fact that public health pays for it. Because of COVID and because we've had delays in people coming to see the doctor and delays in immunization, they've extended that to about age 73, covering the 3 years that we've had COVID. So for the moment in Ontario, if you're between 65 and 73, take advantage and get the vaccine covered by public health. I sometimes see someone who's, 58 or 60, and they ask me, should I wait? Should I wait till I'm 65? And my answer is absolutely not. Risk goes up with age, and you don't want to play Russian roulette and take a chance of getting the disease before you get immunized.
Is that the Shingrix that's covered, or the Zostavax?
So according to public health, you're covered for one vaccine, ideally Shingrix, unless you had the first vaccine, which was Zostavax, paid for by public health. Having said that, I think most physicians are not tracking it that carefully, and maybe we should, but we're not, so that it's Shingrix that we're now giving out as the public health vaccine.
And I think, and just to build on what Dr. Brown was saying there, is that right now, because we do have an audience from across the country in particular, and sometimes well beyond that as well. So right now, if you look at other countries around the world, and we talked about this in our report, United Kingdom, if you look at Australia, if you look at New Zealand, there are a number of other countries that have actually created quite robust programs to vaccinate their older populations with even bigger windows. In Ontario right now, as Dr. Brown was mentioning, 65 to 73-year-olds, because of that pandemic window, are being covered, if you will. In the Yukon Territory, they're now, I believe, covering people above the age of 65. And in PI, they've just announced that they're also providing coverage as well. So it's always important to take a look, and depending, and some other providers, via government providers, I think in Alberta, certain populations are being covered now as well. So this is changing all the time. But what the reason why we're advocating for coverage is we do know from our data that in provinces where there is coverage, some form of coverage, where people don't actually have to pay out of pocket, there's a higher likelihood that people are going to get vaccinated. Because just to be really clear right now, if you're not eligible for a free publicly funded vaccine, the vaccine costs about $300. And so it's about $150 a shot that you pay through your local pharmacy. And so that's why it's really important that when you do get the vaccine covered, and when it's available through or covered by people's insurance, then it really does help to boost up the number of people getting vaccinated as well. So again, we really try and encourage people to find a way to get to get the vaccine. But when it is covered, it certainly does take away that financial barrier for so many older adults as well.
Samir,
Yeah, I think, go ahead, Ruth.
So I just want to add that I believe First Nations is covering shingles as well, and that's a large group, particularly out west. But I just wanted to use a phrase that I use with patients. We always talk about the cost of the vaccine, but I think we also have to talk about the cost of not being vaccinated, because the cost of not being vaccinated is not just the healthcare costs for the province, whatever province it is, it's the cost for the individual, pain medication, time off work, time caring for an older relative. There's a lot of indirect costs when you choose not to be vaccinated. And I just like to make that point, because we really value healthcare in Canada. And I think people don't really understand the devastation that the complications of shingles can do.
Yeah, I was going to say, I think, at an individual level, it's really important to be watching what your province is covering in the publicly funded program. But for people who are working lots of insurance programs, precisely because they understand what they're going to be spending, are now covering the vaccine for their members. So that if you're working, you should check your drug plan to see whether Shingrix is covered. It may well be. But this is at a population level. I think this is also a message to everybody on the phone that what we are doing here is creating inequity. That people who are employed, that people who have money can protect themselves, and people who can't afford it cannot. And this is a recurring theme with vaccines in Canada because of the way we fund vaccines through public health programs that makes it harder to put the money in them and to implement them. It was true of pneumococcal vaccine for kids when it was first introduced, so it's not just an adult problem, but it's worse with adult vaccines because there are more adults than there are one-year-olds, okay? So it's just one of those things. But that means that all of us who want Canadians to be protected need to be out there advocating for public funding for these vaccines and for a change in our funding process so that we can actually get people vaccinated. Everybody agrees that older adults should get vaccinated against zoster. We just haven't figured out how to do that in Canada yet. And that's particularly after watching all of the inequities that have happened in COVID, you really hope that this is the time that our eyes are going to be opened and we're going to be able to say, we can fund adult vaccines in Canada. We know they're cost effective.
And I want to reinforce that point that Allison just made and that Vivien was talking about too. It's because right now we know that the biggest #1 barrier for people, and we know this is why we didn't charge people for the COVID-19 vaccine. We made it freely available and we did a really good job getting 94% of older people vaccinated against it because we really wanted them to get vaccinated. We want to take away all those barriers. So even helping fund, barriers like transportation or translation, even bringing the vaccine to people in their own homes if they were homebound. So we know actually how to do a good job vaccinating our populations. It's just the question is, is there enough political will to do this? Because I think what Allison really called out clearly is something we really focused on in our report, is that we need to make this publicly available. And it's something that it's a worthwhile investment we're paying for, because it's not so much the healthcare system costs, the cost of hospitalizations or that's sometimes the economics of how provinces will say, we'll fund this because it'll save us money for this particular population that costs us a lot in hospitals. But I think what Vivien and Allison were talking about before is it's the idea that personal cost, and that personal cost that's even harder for lower income people to bear, is that if you get that post-herpetic neuralgia, and I've had so many patients who've had this, sadly, it can be devastating. It can really ruin your quality of life. It means that you might not be able to return to work for a while, and that can create even bigger problems for folks who have other challenges already. So again, I think Vivien and Dr. Brown said it really nicely when it's thinking about your own personal health and well-being. Think about the value that this could be, especially if you do have to pay for it. I always say to people, it's an investment worth making, but we know that more and more there'll be better equitable access to this if we don't even have a payment that people have to even worry about.
Yeah. And Samir, I would totally agree with that. And I would add in that the cost of not being vaccinated is sometimes the cost of the loss of independence. People are not able to live with whatever other chronic diseases they had in their own home or in their own apartment, because often a bad case of shingles can just destabilize everything else. And so when we're looking at admissions to long-term care, and we're looking at some of the costs, we really have to think about that loss of independence and what that means for an individual.
Excellent. Thank you very much. While we're on the topic of the vaccines themselves, there's a number of questions coming in, again, on a similar theme. And I'll sort of paraphrase to merge multiple questions into one. But essentially, what if you miss the second dose of the 2-dose vaccine? Are people encouraged to get the full 2 doses again, or can you get the second dose despite some time lag, depending on the individual in question? And I suspect this will come up quite a bit, especially with the interruption of the pandemic the past couple of years.
So I'll answer it because Allison has taught me this very clearly. You don't start over. You pick up where you left off, unless you're a bone marrow transplant patient where you've lost all your initial vaccine immunity. So whatever multiple series vaccine it is, HPV, hepatitis, shingles, you just pick up where you left off. You may not get as good immunity as you would have had you followed the protocol exactly, but in general, you still get good immunity and you just pick up where you left off. So you don't start the series over.
Thank you. And here's a question that I don't know how many people are thinking about it, but it's a pretty good sort of devil's advocate. Anonymous asks, if the vaccine is only good for 4 years, maybe 10, why would you get it at 50 and not at 65 so you're better protected when you're much older rather than earlier in your elder years? Assuming some people are thinking this way, what would be a good response to those people?
So let me walk out on that limb, okay? The first thing is every reason to believe that Shingrix is going to work for much longer than 10 years. The problem, so you just heard Dr. Brown tell you that it was first licensed in 2017. So that's the experience we have so far. 4 years, hot dog, okay? It's good for 4 years. We're gonna find out over time if it's good for 20 or 30 years. You're obviously not gonna wait to start a vaccination program to find out whether it works for 10 years or 20 years or 30 years. So when we start vaccination programs, we start them because we know the vaccine works for long enough to be worthwhile. And then we put in place surveillance systems that ask us how long it works. If the effect declines over time, so the most recent example of this is the pertussis or whooping cough vaccine, okay? We have a new vaccine that works very well with much fewer side effects, but we've discovered that it wanes over time, and so adults need a dose of it now. That was a change because we found out what happened over the long term with pertussis vaccine, and we'll be doing the same thing with shingles vaccines. We'll be watching. If you get it at 55 or 60, yes, you might need it again when you're 80 or 85 or 90, but we'll know that when we get there, and you'll be able to get your next dose. So you really, the issue is at, I think people argue about whether the cut point is 50 or 55 or 60 about when you should get your first dose of the shingles vaccine. But you should, once you and your doctor have talked about it and have decided that you should get it, you shouldn't delay it because you want protection later. You should be able to say, I'm going to get the protection now. It's good for, with Shingrix, at least 10 years. And at the end of that 10-year period, we'll know what to do, and I'll do the thing that's right then.
Yeah, and I think we're hearing that question about other vaccines too. I think I've had some patients, for example, asking about COVID boosters and saying, for that 4th dose, maybe I'm going to wait for when I'm planning to go traveling. And I'm like, nope, that's not a thing. If you're eligible now, you get it now. So I think it's that notion again. I think as Dr. Brown was saying earlier, and Dr. McGeer was saying earlier, it's think about that quality of life piece. So the good news is that we know that it is, our National Advisory Committee on Immunization has looked at the data saying, we recommend it for people 50 and older and younger people if they are immunocompromised and from that perspective. But this one we recommend, for routine vaccination, to go from 50 and beyond. And the good news is, like Dr. McGeer and many other scientists, this is where they're constantly looking at the data to then give us further information. So better not to hedge your bets and say, maybe I'll wait till 60 or 65. Better to get all the protection that you can, knowing that, if they're, and then staying informed. And one thing that we usually recommend, and I'm sure Dr. Brown does this in her practice, is that, I always say that, every year you have a birthday, it's always a good opportunity next time you see your primary care provider to say, are there any other, am I up to date on all my vaccinations? Anything new out there that I need to know about? Because that's when you might hear from Dr. Brown or others, hey, actually, you know what? You had your shingles vaccine 15 years ago now, and actually the new evidence is saying you're eligible for a booster at this point. So always good to kind of use your birth date as a date to kind of just prompt a conversation with your primary care provider to find out what's new in vaccines, any things, because things are constantly changing as we make more progress in this area too.
Thank you very much. Another question that's come up in multiple forms, and it actually relates to the birthday comment you just made, Samir. A number of people wondering, should I wait until 50? What if I'm 48, 49? And Dr. Vivien, we were talking a little bit about this before the show started, about what should younger people who wonder if they're at risk or who are maybe just out of abundance of caution, how do we approach that for people under 50?
So the vaccine is advised for everybody over the age of 50. If you're younger than 50, between 18 and 50, and you have some level of being immunocompromised, you are advised to be vaccinated. And immunocompromised ranges from those people who are kidney transplant patients to people who have autoimmune diseases like lupus and rheumatoid arthritis, psoriasis, or on a variety of medications that can compromise your immune system. So if you're younger than 50, I think it warrants a discussion with your physician. If you're perfectly healthy, have none of those diseases, and you want the vaccine anyway, maybe you have a family history, because that also increases your risk, then you would be taking the vaccine. The term is off-label. It's not advised in that age group, but it's safe to take. And that would be a personal discussion between you and your doctor.
Excellent. And there are some more questions. We might get to it. I'll group it in with the COVID related questions, but there are a number of questions about younger people getting it. But I think there's a good question here someone asked, and I suspect there might be people in the audience who fit the category, who may have had shingles recently, may not have had it diagnosed because of the pandemic. And so they're saying, first of all, how do we know? And what's the purpose of the 1 year wait to get vaccinated after shingles? Can you get it again? How do we sort of unpack that issue for our listeners?
I think if you just had shingles, your immune system's had the reminder of the disease, you've gotten boosted again, and unless there's something seriously wrong with your immune system, and by seriously I mean you're immediately post bone marrow transplants or are on chemotherapy for a hematologic malignancy, a blood cancer, you're not going to get shingles again in the next year. So, and the wait time, remember all this discussion about wait times for COVID vaccines, how long you want to wait between doses? Usually you want to wait at least 6 months between sort of a boost to previous vaccine doses. And a year is probably even better. So the year wait after shingles is to say, if you've had shingles once, you're not going to get it in the next year. We want to give your immune system time to mature and be as ready as it can be so that when you get the dose of vaccine, you get the best response to it. So yes, it's just it can be a little bit annoying sitting waiting for it, because I know, once you've had shingles, then you have a tendency to really want to make sure you're protected in the future. And that wait can be a little annoying, but it really is about trying to make sure that your immune system gets the best possible response to the vaccine after you've had shingles.
I think just building on what Allison just said as well is the issue that if you've actually had, because I have a lot of patients say, oh, I already had a case of shingles, so I don't need the vaccine, I'm protected. But we do know the evidence is quite clear that if you've had a previous case of shingles, that predicts a future case of shingles as well. So that's why we recommend that if you've had a case of shingles, yes, you should get vaccinated, because there's a higher chance that you're going to get a future case as well.
Excellent, thank you. So before I move on to some of the questions that are COVID related, it might be a good idea to get your thoughts on, in general, on any relation or none at all between COVID, shingles, and some of what other people are seeing. I know it's hard for a lot of people who are sitting at home these past couple of years to unpack exactly what's going on, but judging by some of our questions, there's a little bit of a sort of, people raising questions about what do we know about COVID and shingles? Are they related? Are some of the phenomena we're seeing in the news over-reported, that sort of thing? But I'll ask some specific questions later on, but just wondering, I'll start with you, Samir, if you have any thoughts on how people should understand shingles in the context of the COVID pandemic.
Yeah, I think a few just general thoughts right now. It's that one thing that we do know is that because we've been so focused around COVID-19, we've really seen that people haven't been focused as routinely on those routine immunizations. So we've actually seen the usual rates of people getting vaccinated against things like shingles, but also influenza and pneumococcal disease. I'm talking about one specifically for older adults, but even I'm sure Vivien with her pediatric population may have seen that we're not keeping as up to date on our other vaccinations. And I think therefore, not only are we, while we're contending or most concerned about COVID, I think that there's probably been more cases of shingles being experienced because people haven't necessarily gotten the protection that they might have routinely gotten had we not had this pandemic. So I think that's one thing to be aware of. Some people have said, well, does the COVID-19 vaccine protect me against shingles? I don't think there's any evidence to support that because again, we're talking about two very different viruses. But the one good news is that some of the work that has been done to look at the safety of co-administration reminds us that one can actually get different vaccinations at the same time. So for example, you can get your COVID-19 vaccination at the same time as you get your influenza vaccination. And that might be a common recommendation in the upcoming flu season to recommend that. But you can also, I believe, it's been confirmed now that yes, it is safe to also get your shingles vaccination at the same time as your COVID-19 vaccination as well. But again, again, the nice part is that we've got some good data of how these things can be thought about in relation to each other. But getting one vaccination doesn't protect you from the other disease. But I am not the expert here. I always defer to Dr. McGeer to correct me if I've made some mistakes in what I've said. And Dr. Brown always has very practical advice as a frontline family doctor. So I'm going to defer to them in case I've said something wrong or that something could be clarified even better.
Yeah, no, Samir, I absolutely agree with you. I think adult immunization, whichever immunization we're talking about, is not up to the standard that it should be right now. So we've got people under immunized, and we need to protect people so they don't end up in hospital, so they don't end up being in some long-term care facility. And you can do multiple vaccines at the same time. So I sometimes am giving a pneumococcal vaccine, a shingles vaccine, a tetanus pertussis vaccine, and a flu vaccine all at the same time. There's a lot of vaccines for children that are already combined. When we give MMR, we're giving measles, mumps, rubella. It's safe to combine vaccines. We've got good guidance from NACI to combine vaccines. And once the patient is in, once you're seeing your family doctor and you're there, get up to date. That's your time. So I think it's important that we talk about vaccine to every patient on every visit and make sure people are as up to date as possible.
Dr. McGeer, did you have anything you'd like to add?
No, only to say that looking at the questions in the chat, I think one of the things that some family physicians are nervous about talking to people about vaccines they have to pay for. The Canadian tradition, I think, is to think that if a vaccine is worth having, it'll be covered. And if public health isn't paying for it, then people don't need it, or maybe there's something wrong with it. And that's definitively no longer true. It's just a little bit hard for us to get out of the mindset. It's also true that in general in Canada, I think we like to think that healthcare is paid for, that public health takes care of us. And so I think that some physicians are nervous about talking to their patients about vaccines that they have to pay for by themselves or that might only be covered by their insurance. And particularly if it's, they don't know the financial situation of somebody in detail. So it does help, I think, to tell your family doctor that you want to hear about everything, that you, even if you might choose not to spend the money, that you want to be up to date with your vaccines, you want to know what's going on, because that allows them to then have the conversation with you about vaccines that you might pay for, that they might be nervous about talking to you about.
Mm.
And just to add to that, it's very interesting that when a study was done asking doctors about barriers to adult vaccine, most doctors think that cost is the main barrier. And when they asked patients what the main barrier is, most patients said it wasn't recommended, that they weren't educated about it, they didn't know about it. So I think we have to get on the same page, and we have to err on the side of education, and then people can make their own decisions.
Yeah, more of a comment than a question, but on that point, someone saying that primary health providers need to talk to their patients about vaccination. A lot of people don't know about it, and I'm assuming that comes from some level of personal experience from this person. But back to the COVID, just to burst the bubble, because I know there are people sitting at home, and in my line of work, I get asked questions that I'm not actually equipped to answer. So we have you here, but why do people have the sense that younger people are getting it? I'll ask very clearly. Lynn here says, Justin Bieber has Ramsay-Hunt syndrome. Is this a related disease? How do we sort of help people at home understand what the headlines might be sort of telling them wrongly or correctly?
So I think it's fair to say, if I can answer this one, that younger people do get shingles, but just in general, it's rare for younger people to get major complications. Justin Bieber is an unusual case. This is related to varicella virus. It is related to shingles, and Ramsay-Hunt is one of the risk or complications that you can get, but it's actually pretty rare to have it in someone as young as him. His stress level must be high. His immune system must be compromised. I understand he had Lyme disease for a number of months, so there must be something more going on. The reason we generally are not immunizing healthier younger people is because the way Allison described shingles as a minor rash and it can come and go, We're not immunizing to prevent every episode of shingles. We're really immunizing to prevent the complications of shingles. And that's what we see more likely in older people. The older you are, the more severe the disease, and the older you are, the more likely you are to have complications. So I actually think we need to thank Justin Bieber for talking about this, and Ramsay Hunt is important, but it's pretty rare.
Okay. Moving on, actually a question that I think will be worth, Sandra is asking a very specific question, but I know Dr. Vivien, we talked a little bit about it. Happy to hear from anyone. She says, I had a very serious reaction to the DPT vaccine at the age of 10. I was told then by the doctor that I should not receive the vaccination again. Will the shingles vaccine risk causing the same or similar reaction? She says extreme swelling of the arm, fever, and ill for about 2 weeks.
So I'm assuming that this is somebody who is an older adult, and it is absolutely true that those of us who are older adults got a lot of diphtheria, pertussis, tetanus shots. Okay, we were, you know, in the era when they were new, we were coming off the situation where there were tetanus wards in hospitals. People died of diphtheria. We were completely focused on prevention, and for quite some time, we actually over-vaccinated people against diphtheria and tetanus because we were so concerned about wanting to make sure their protection was good. And the problem with getting a whole series of tetanus shots is that your immune system is then really primed, and you do get really big sore arms when you're on your 5th or 6th tetanus shot in a short period of time. So that's likely what happened in this circumstance. That's a local reaction that has to do with your body's response to an antigen that they've met multiple times before. And there's no reason to think that any vaccine, so it's probably been long enough. If it's more than 30 or 40 years since you had a tetanus vaccine, you're almost certainly not going to get the reaction again, but you're certainly not going to get it in association with any other kind of vaccine. That reaction is specific to the particular disease that you're being immunized against. It's not related to vaccination against other diseases. But it is something that you should sit down and talk to your doctor about. And if there's a level of concern after that, there are physicians who are specialists in allergic reactions to vaccines and managing vaccine adverse events. So the fact that you want to be up to date with your adult immunizations means make an appointment, sit down with your doctor, talk your way through whether there's anything to worry about or not.
Excellent, thank you very much. And Allison, you mentioned this, the disconnect between recommendations and public coverage, and that sort of system is broken. But do you have any good answers for why the vaccine, I'm assuming in Ontario here, isn't covered after the age of 75 written? Let's go with the facts as they understand it. Is there a good reason why it's not funded for significantly older people, or is that just the tick of the system?
Okay, so let me tell you what the reason is, okay? Provinces in Canada are in charge of paying for health, including public health. So we pay for vaccines, but we don't pay for vaccines within the healthcare system. The healthcare system that spends essentially all of the money, and then we have a public health system. Our total spend on public health, including all your vaccines, pays for 3 hospital days, okay? So we underfund and under-resource all public health. Vaccines are part of the public health budget. So when we buy a vaccine, whether it's to vaccinate kids or adults, it's in our provincial public health budget, which is already really small. And so despite the fact that we could pay for shingles vaccine for adults in Ontario for less than the cost of rituximab, which we fund for good reason for lots of diseases to treat the disease. Our vaccine budget is a really small fraction of our drug budget, but it's separated out, and in the silo it's in, it looks big. And when you introduce a new adult vaccine, so let's say we wanted to say every adult over the age of 65 should get a shingles vaccine next year. That's a lot of people, okay? We've just demonstrated that with COVID, right? And it's a lot more people. When we introduce pediatric vaccine, we start with a birth cohort, right? And so we vaccinate everybody who's 0 to 1 in the first year, right? But if we're introducing a public health program for adults, let's say we start at 50, that's millions of adults, okay? So that the budget balloons up and it comes back down again, but we have no capacity to take that budget balloon and do something with it. We're not used to doing it. We don't think about doing it. And so we have for vaccines in Canada, what is called a budget impact problem, right? We know they're cost effective. We've agreed we should be paying for them, but we don't have a mechanism within the government for absorbing what is, relatively speaking, compared to healthcare, a pretty small cost, but relatively speaking, compared to what we spend on public health, kind of a substantial cost, and coping with it. And it's just that simple. We should be paying for shingles vaccine and pneumonia vaccine for adults who are over 73, but we haven't figured out how to do it yet.
So is it fair to say, these are my words, that if someone's out there and they see that it's not funded over 73, that doesn't mean that they shouldn't take it, right? Because I think some people might be reading it that way.
Yeah, well, yeah, and it is this again is that really in-depth feeling that if the government, if the National Advisory Committee, if Dr. Brown, if Dr. Sinha thought that this vaccine was good for people, we would be paying for it, because after all, essential things are paid for in our healthcare system, right? So if they're not offering it, it must not be worthwhile. And that's a really hard conversation to have with people, because it doesn't make sense that we're not paying for shingles vaccine for people who are 74 when we're paying for it for people who are 73. And it, we tend to like to think that our healthcare system and our government makes sense. And so when you run up against these, it's just stupid. It's hard to cope with.
Yeah, and I agree, Allison, completely. And I think, Michael, one of the problems is when we do a really good job with vaccine, COVID being the exception, but when we do a really good job with vaccine, what happens? Where's the front page story? There's nothing. When we do a good job, so there's less hospital admissions and more people stay in their house and less people get sick, that's not a big story. And when you talk about healthcare spending, what makes a bigger story is whether you're getting a new MRI machine, or whether you're getting a new hospital, or whether you're getting more hospital beds. Vaccine is not quote unquote sexy, because when we do something great, there's no story, there's no publicity.
There's
Sorry, go ahead.
A number of articles from somebody who was the former director of the US Institute of Medicine called "Why Prevention is a Hard Sell," and it's exactly that. You can write a story about new organ transplants. You can save lives with treatment, but you can't see the lives you save with vaccines. And that inability to understand the benefit, to actually feel the benefit, just makes it much harder for people to organize themselves to fund vaccines than to fund diagnosis or treatment.
Okay. Well, and on that note, Samir, I'll ask you, as a practicing geriatrician, Daniel writes, I am 90. Is it worthwhile to get the vaccination?
Yes, yes.
100%. And I just want to build on what Dr. Brown and Dr. McGeer were saying, is that, again, I think people are asking this question because we've got the system that if you're in Ontario right now, so if you're in Manitoba next door, if you're in Quebec, for example, it's not covered. So people probably assume that it's not worth getting because the government doesn't cover it. And then we have this situation in Ontario where if you're 65 to 73, it's covered. But what do the 50 to 59-year-olds think, or sorry, the 50-year-olds to the 64-year-olds, and what do the 74 plus people think? Again, it's that notion that, well, probably I'm out of the window and it's not covered, so it's probably not worthwhile. No, it is. So I with every single one of my patients I don't really have patients in their 50s. My patients start, at least in their late 60s and older. But for everybody, again, I always ask everybody, where are you at with your vaccinations? What are the barriers that we can resolve? And I've just seen way too many cases of patients who said, now, Dr. Sinha, I know you think it's important, but I'll be fine. I won't get it, or I've lived this long. I've lived till I'm 90. I haven't gotten shingles. So why would I get it now? And I remember I had a patient in my very first year of practice in Baltimore, who I was begging to get the vaccine. She was putting me off, and then she got a devastating case of shingles. It was her case in particular, kind of like our friend Justin Bieber, was right along her face. She lost some teeth, and the sad part was that the rash came and went within a week for her. That wasn't the big issue. It was that post-herpetic neuralgia. She had such a level of pain that even she loved to sit out on the veranda of her house and just watch, the kids and life go by. But she would no longer sit out on the veranda because just the wind touching her skin was so painful that she didn't even want to go outside anymore. And so every time I saw her, she said, please tell your patients about my story. Tell them that this is real. Tell them that you begged me and I said no, and now I'm paying the consequence of this. And don't let any of your other patients do what I did. So I'm sharing her story, from that perspective, because again, this was a person who was 87 years of age, and who has said to me all the time, I've been 87, I haven't gotten it now, so I'll probably be fine. And then then it just hit her. So again, what we say is anybody older than 50 is eligible, and whether or not it's publicly funded. I always say, sometimes when I have family members in, with my patient, I'll say, what would make a great birthday present, or a great Mother's Day present, is probably something they want, but also, get them a shingles vaccination as well. So I always try and kind of remind people it's a really worthwhile investment, especially when it can really preserve one's quality of life. And as Dr. Brown was saying, just even your ability to live independently. And so much of our work at the NIA is focused on helping people stay healthy and independent for as long as possible. This is whenever I say to my patients, what's your goal? And they say, that's my goal, Dr. Sinha. That's what I want to do. Then I'm like, yeah, then you need to get vaccinated. So for that 90-year-old, absolutely. If you haven't been vaccinated, see your primary care provider, start the conversation. And the other thing is that you can actually get the vaccination through your pharmacy as well. So you can actually ask your primary care provider for a prescription. You can get it done at your pharmacy, or your primary care provider can often do it for you. And if you are eligible for the publicly funded one, you can get that through a public health unit or your primary care provider, but not through a pharmacy. So again, it's always important to have a chat with your primary care provider, no matter what your age, just to find out what you're eligible for. Because if you haven't gotten your shingles, then I'll also say, are you up to date? Have you had your pneumococcal vaccination? Are you getting your influenza vaccination on an annual basis? Are you up to date on your tetanus? Are you up to date, and are you up to date on your COVID vaccine series? So again, always a good conversation to have. What vaccines am I eligible for? And I think as Dr. Brown made a really nice comment, because so many people, or it was Dr. McGeer, both very smart women, who made that comment by saying that with so many physicians afraid to mention vaccines that one might have to pay for, it's good if you can be proactive, break the ice and say, look, tell me about everything I'm eligible for, and then I'll figure out whether I think it's worth the investment.
I think one of the issues with vaccination for people who are 85 or 90 was when we had the first shingles vaccine, there was some indication that it didn't work as well as people who got older. As people got older. And so I think there were some physicians there who were saying, I'm not sure if I should vaccinate my 85 or 90-year-old because I don't know how well it's going to work. And because we knew at the time that there was this new vaccine coming, that, maybe if it's not going to work that well, I should wait for the new vaccine. But so a piece of this, as Dr. Sinha has said, is you really have to sort of stay up to date with what's happening to adult vaccinations, because we're making pretty rapid progress on a bunch of things. And so which vaccines you should should have are changing. And very definitely now that we have Shingrix and we're moving into the inactivated vaccines, there was no indication in those trials that people who were older were less well protected than people who were younger. So it really has shifted to say, yes, definitely we should be vaccinating everybody.
Excellent. So final question before we start wrapping up, because I know, Dr. Vivien, you had mentioned immunosuppressed individuals. There's some questions around that. And I think there might be a sort of sense of what does that mean technically versus, generally older people's immunity waning. So I'll fold it into two. Feel free to answer it as you like. But where does one find the definition of immunosuppressed for the sake of eligibility? Kathy asks. And I think not unrelated, Shirley asks, if you had the vaccine and then later undergo chemotherapy, are you still protected? So I think there's some questions about that interaction with immunosuppressed individuals.
So generally in the guidelines from NACI, from the National Advisory Committee on Immunization, they spell out who qualifies as immunosuppressed. Mostly it's people with solid organ transplants, people with immunosuppressive diseases, autoimmune diseases, and people who have been transplant patients, kidney transplant, whatever, as well as the drugs that people are on for various diseases, like the infusion drugs, some of the new biologics. If you're not sure, and yes, I'm biased as a family doctor, but if you're not sure, it warrants the conversation with your physician. Are you significantly immunosuppressed? Should you be vaccinated? And, we got very clear guidelines about immunosuppression when the COVID vaccines were first launched, because we gave it to people who are immunosuppressed preferentially. So I think it's a discussion. Not every drug, it depends on the dose of some drugs. For example, prednisone, methotrexate, some drugs that are used for rheumatoid arthritis, it depends on the dose, not just the fact that you're on the drug. And so this is a conversation as an individual that you should have with your physician.
It really is getting more confusing because we're increasingly getting medications that modulate your immune system. They're not always immunosuppression, and sometimes they suppress a piece of your immune system, but not all of it. So it is getting increasingly complicated to look at vaccines and say, this person is immunosuppressed, and so they should get a dose of vaccine, or this person is immunosuppressed and they might not be quite as well protected with one dose, so they should get 2 doses. It is getting more complicated to make that decision because of the number of really good medications we've got for a variety of diseases now that work by modulating your immune system.
Excellent, thank you very much. Well, we only have 2 minutes. We're retaining about a minute just to close things off. Maybe I'll ask each of you to give us 20, 30 seconds. What's your sort of big final parting thought to the audience? Samir, we'll start with you.
Just have a chat with your primary care provider, your next opportunity to find out what are the vaccines you're eligible for, and try and stay up to date, because that's the best way to maintain to staying healthy and staying independent.
Excellent. Dr. Brown?
Yeah, I think vaccines are some of the most exciting work that we do, and I would encourage everybody on your next visit with your physician to review your personal status. Because what's covered for the province, or what the advice is, what's recommended but unfunded, it all comes down to you. We talk about personalized medicine. It's what's best for you, for that 90-year-old patient that asks something, or the 50-year-old who's not immune suppressed, or the 30-year-old who is immune suppressed. The idea is find out what's best for you and follow through.
Dr. McGeer?
You can actually, so you can take it one step further if you're waiting for your appointment with your family doctor, which is if you go to the website of the Centers for Disease Control in the United States, or a website called Immunize Canada. There are questionnaires on those sites where you can ask yourself which vaccines you might be eligible for, fixed vaccines you should have. So you take a little bit of time to look at that before you go to your doctor, then your questions will be more informed. And you'll be, I think, more ready to take the recommendation of your doctor about vaccines. But it's really, I think it's a little better, but the last time the government of Canada asked adults whether they were up to date with their vaccines, right? I know we've used the statistic a lot, but 97% of people said they were up to date with vaccines, and 3% actually were, right? So none of us functionally are up to date with our vaccines, and we really need to make a move if, as Samir says, we want to stay well and healthy for as long as we can.
Excellent. Well, that brings us to a close for today's session. I think this quite possibly could be the most informative session on shingles in the world happening right now. We have 3 of the world's top experts here for us. And thank you again, Dr. Sinha, Dr. Brown, Dr. McGeer. Judging by the comments, you answered a lot of really important questions that a lot of people had on their minds clearly for quite some time. Thank you to our audience. This session has been recorded, as you noted. It'll be made available shortly after this airing. Feel free to share it with your network. If there's anyone you think might benefit from learning more about shingles, please do share that. And a big thank you to GSK again for sponsoring this event. Thank you all for joining us, and have a good afternoon.
Thank you so much. It's been a pleasure.
Take care. Bye-bye.
Goodbye.